talk is on how does all inside ACL reconstruction compare with a standard anatomical ACL reconstruction. So it can be a little repetitive because the previous speakers also have spoken. So I'll try and be very short and less repetitive. So the difference in between the two is that in an all inside, you use suspensory fixation on both ends. So there is no tibial screw involved, and you have adjustable loop endo buttons on both sides, and you create sockets rather than tunnels. And the most important is even after you have tensioned the graft at the end, you can again cinch it if it has become loose. So that is a very important point. So these are the basic differences between the two. And there are some differences with regards to all these points. So we'll just take them one by one. So Dr. Rohit told you about the graft link. So the graft which is used in an all inside ACL reconstruction is called a graft link. There's a different way of preparing it. And there have been ample studies comparing the ultimate failure load of graft link, and they say that it is as good as any other graft. So semi-T is more than enough. I mean, it's like in my practice, I have to take a gracilis maybe 5 to 10% of the times. Otherwise, it's just semitendinosis. And a strict advice is do not have a graft of more than 250 to 280 millimeters. So that once you quadruple it, it should be between 60 to 70 and not more. And a graft diameter of 9 or 10 is usually good. So Dr. Rohit has told you how to make that graft, but if you still want, you can go ahead and see this article by James Lubowitz, who is like one of the pioneers of all inside ACL reconstructions to understand graft preparation better. Because the graft link is a very important part of an all inside ACL reconstruction. Then in all inside, you create sockets rather than tunnels. So you're saving on bone, it's bone preserving, your cortex is also spared. And there are studies which say that all inside ACL reconstructions are less painful post-operatively. And I found this one article which says that retrograde drilling with a flip cutter of the tibia resulted in less bone edema and subsequent pain. So that is one good thing in favor of all insides and a flip cutter. Then I usually do the femoral tunnel using a standard accessory anteromedial portal. But there is this article by Dr. Adrian Wilson, who is also a very big proponent of all inside ACL reconstructions, where he tells you the advantages of using a femoral flip cutter tunnel using a femoral flip cutter. So it's more anatomic. There's no accessory medial portal involved. You don't need to hyperflex. There is no posterior wall blowout. The problem of short tunnels is not there, and the problem of misplaced tunnels is also not there. So look up this article if you are interested in doing your femurs with a flip cutter. Then the other difference in between the two is that we use adjustable loop buttons on both sides. So there is ample evidence in literature to support the use of cortical suspensory buttons versus aperture fixation, wherein there is no significant difference in knee AP stability or other outcomes when you compare the both techniques. In fact, there are studies which say that anterior cruciate ligament reconstruction is associated with greater tibial tunnel widening when using a bioabsorbable screw compared to an all-inside technique with suspensory fixation. In fact, I could find another article from arthroscopy which had assessed histological fixation of an all-inside ACL graft link in a large animal model study, and which said that there was associated with superior tendon to bone healing with when they were doing it with all insides rather than with interference screws. So I have my own issues with the screws. I know everyone might be having nothing against standard traditional anterior cruciate ligament reconstruction, but there are some issues. Like I still don't know where should I be putting my tibial screw. Should I be putting it very near to the distal cortex where there is a good hold, or should I take it up to the tibial plateau where the bungee cord phenomena would be less. So there's still a doubt of that. Then whenever I use a titanium screw, the threads or the ethibond sometimes get slashed, and you're helpless with that graft not fixed on the tibial side, and you have to open it up again. Then in soft bones, it's the screw does not compress the ligament to the bone as it should, and then you get some kind of laxity. Then there are issues of screw divergence, and then there's issues with guide wires. Like I just had this very recently, wherein I put in a titanium screw, and I tried to pull the wire out, and it just did not. And my assistant then pulled it very hard, and it broke. And we did a CM picture, and this was the scene. So we had to remove the graph. We have to remove the tibial screw, and then remove the guide wire, and so on. So there are issues with the screw. There's infection. I found that whatever infections I've had in my kitty, they've been mostly on the tibial side with such kind of pictures. And then there are special circumstances wherein all inside ACLs have a major role to play, like multi-ligament injuries, where you have to make multiple tunnels in the bone. So it is obviously very important that you save as much bone as you can. And then in the skeletally immature patients who have an ACL injury, so it's much better to do an all inside ACL where you can, save the physes, and this is how you do a femoral tunnel, taking good images on the C arm and seeing whether you're not going through the physis, and then using a flip cutter on the femoral side as well, and then doing the same thing on the tibial side. And that is how you are saving the physis, and you have an ACL done without injuring the physis at all. So a very big boon in patients with skeletally immature. There are certain technical difficulties which you will face once you start doing your all inside ACL reconstructions. Now it's been for 5 years for me that I've started doing these. And I can tell you that the graft link preparation has to be very precise, and it is you cannot have it as a weak link because it would fail then. And initially it takes time when you are new to it. The graft preparation takes time, but you save that time on putting in your screws. So as of now, for me, it's like both take the same time. So time is not a problem, and your team also gets used to these things. You should get accustomed to using the flip cutter, because that is one device which you can get stuck with sometimes. So that takes a little time. And as Dr. Aditya mentioned, graft passage is very important. So you should not have a soft tissue bridge in between. So you make your accessory anteromedial portal very big, so that your whole graft can go easily, and make a virtual cannula using a suture manipulator. And in the initial stages, you can use a no button tightrope and then an ABS button, so that at least the button does not get stuck when you're pulling your graft down through it to be a tunnel. And a couple of pointers from my side, that when I've had my share of complications initially with the all inside. So we were cinching the button on the tibia, and that button, rather than going horizontally onto the tunnel, it just went vertically inside, and then the loop was short, and then we had to open it up. So look at the button while you're cinching on the tibia. It's very important that you place it directly on the cortex nicely. Look at it and do it. And I've had a case a couple of times when on the femoral side, the loop got loosened up, and the button came into the soft tissues. Then I had to open it up and then cinch it all again. So now what I do is on the tibia, I'm sure everyone else does tie the cinching sutures onto the button. So what I've started doing is on the femoral side as well, I just make a small nick, and I use a knot pusher to tie a couple of half-inch knots on the femoral side of the button as well. So cost is definitely an issue. It's a little more expensive than your standard fixed loop and your bio screws. But somehow it has given me a peace of mind, and I am very happy with my all inside reconstructions, and that is my primary way of doing all insides now. And we are waiting for this flip cutter 3, which will have many more applications, rather not just for ligament surgery. I'm sure trauma surgeons will also be able to use it, because it has a wide range of angles in which you can drill. So coming to results, there is ample evidence to suggest that the results of all inside ACL reconstructions are as good as standard standard ACL reconstructions. So I have articles from 2013, and every journal you want, knee and arthroscopy. And there's from 2019 where they say that because you are not using the bacillus, you're only using one tendon, there's superior knee flexor strength at 2 years with all inside short graft anterior cruciate ligament reconstruction versus a conventional hamstring technique. So there is ample evidence to show that the technique is in here to stay, and eventually when we learn more about it, the results are going to get better and better. As of now, they are not statistically more better than the standard ACL, but I hope so they will someday. So for me, why all inside ACLR? I mean, it's very simple. You create sockets rather than tunnels. There is less bone removal. There's less of windshield wiper and bungee cord phenomena. Semitendinosis is enough. You don't need the gracilis. And small grafts, even 60 is perfectly fine. And there are less functional deficits, less post-operative pain. And in soft bone, never use a screw, always do an all inside ACL. And the best part is you can cinch again after tensioning. I mean, you've just cycled the knee and you find that your ACL is a little lax. What do? You can't do anything if you've done a standard ACL, but here you can cinch it on either side, and just 2 to 3 millimeters of cinching and your ligament is tight again. And then you tie the knots, it remains that way. And in skeletally immature and multi-ligament injuries, I think this is the way to go.